Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if we'll go to the next slide. So the first update is that HEDIS has put out, NCQA has put out the proposed HEDIS changes for measure year, excuse me, 2025. Comments on these proposals are due March 13th. There are 5 new measures that they're proposing, and they've also proposed updates to 5 measures that currently exist. I'm not going to read out the measures. You can see them on the screen, and let's go ahead and go to the next slide. There are also a couple of overarching proposed changes, sort of 2 goals. One of them is to make various measures more gender inclusive. So some of the gender specific measures, like chlamydia screenings for women, have been reworded and rewritten to encourage the inclusion of transgender and what they're calling gender diverse patients who are currently being screened at a lower frequency than cisgender patients. So that's one change. They're also proposing, based on user feedback, the removal of the provenance requirement for race and ethnicity data. And this one is a little bit more problematic and controversial. There was some feedback that it was too burdensome, and I'm sure this is something that there will be a lot of discussion about. And I'm sure that we will discuss that. We will likely take a look at these measures in a future meeting, and I'm sure that we will have a lot of discussion around that as well. So you can find a link to the changes there. Does anyone have any initial questions or thoughts? All right, then let's go ahead and move on. So there was an announcement of 2 new QHINs. They are basically under the same rules and regulations as the existing QHINs. They are Commonwealth Health Alliance, and I assume that said no to, but I don't actually know that for certain. There is a link to the announcement. There's not a ton of additional information there. There are some other candidate QHINs that are in the works that may be announced at any point in time. Basically, the process is as soon as 1 or more candidate QHINs meet the criteria, they get promoted. So there's no set schedule, like once a quarter there'll be new QHINs or anything like that. It's basically on an as folks are ready basis. So any questions or comments or thoughts there? All right, let's go to the next update then. This one came via email, which is why there's no link. And we talked previously about some extensions to the independent dispute resolution process for No Surprises. They are currently in place through March 13th, and they're going to end on March 14th. Most of these were just some additional time to deal with submission and response processes. But one thing they call out in particular is that improperly batched disputes may be fixed and submitted only once, and that has to happen within 4 days of the notice that they were improperly batched. Right now, with the extensions that are in place, there apparently you have 10 days to do that resubmission. You still only get to do it once. And if I remember correctly, they might be calling that out because they didn't highlight this particular extension when they did the announcements about the extensions originally. So this may be more of a, hey, just so you know, right now you do have the opportunity to have this extra time, but that's going away in a few weeks. Any questions, comments, thoughts there? All right, let's move on then. So CMS has put out an update to what they call the Mapping Medicare Disparities tool. And most of what they've done is add new data. You'll notice the data is a bit behind. For Medicare Advantage, they've added 2018 encounter data. So that's, basically 5+ years behind. And then they've added preliminary 2022 and final 2021 fee-for-service data. And they've also added an extensive amount of SDOH related data from 2020. And that's available by county, by state, and by census tract. In addition, they've added a bunch of new measures or views of the data, including a market saturation measure, information on alcohol and drug use disorders, more information about sickle cell disease and behavioral health. And they've also added some new filters. The first one is to filter by either Medicare Advantage or fee-for-service. And then they also have a hospital comparison tool now that allows you to compare different hospitals to each other or to look only at hospitals within certain geographic areas. And that can be sort of filtered downward. So you can find that tool at the link there. Any questions, comments, or thoughts? As noted, that data is a fair bit behind and it varies by type of data. So bear that in mind if you do take a look at the tool. All right, let's move on. So ONC has put out the 2024 ISA reference. ISA is the Interoperability Standards Advisory. Excuse me. And so this is a comprehensive list of all of the current supported standards around anything interoperability related. And it's organized into categories of vocabulary and code sets, content and structure, services and exchange, and then administrative. Inside each category are specific topics, and each topic has an entry that covers the relevant standards, the applicable types of interoperability, which would basically be the types of use cases it applies to, how mature the different standards are, whether they're required by any federal rules, any limitations or dependencies they know, and then any relevant value sets. So you can find the new edition there. It is a fairly large PDF file, but it's basically, if you're trying to find things by use case or topic area, it can be helpful, but it crosses across all different programs, all different interoperability mechanisms. And so it's just kind of a really big reference file. Any questions, thoughts, comments there? All right, moving on then. So this one's interesting. So this is also an interesting and useful file. So DaVinci has put up a delta between US Core 311 and 610. 311 is the official version for US CDI version 1. 610 is the official version for US CDI version 3. And so the idea here is this is supposed to help different implementation guides plan a migration to fully supporting US CDI version 3 as part of HTI1 moving forward. So there were 9 resources that had significant changes, including patient encounter and provenance, and there are 24 new profiles. Now, a lot of that sounds like a lot, but a lot of them are specific profiles for a required vital sign, which was not the way that was handled in the past. And there's also a general observation profile. But one thing that's interesting is that there didn't used to be a US core version of questionnaire resource. They used to use a questionnaire resource from a different implementation guide, and there's now a US core specific version. And they've also added US core specific coverage, related person and specimen. In addition, there are 3 new extensions for jurisdiction, tribal affiliation, and questionnaire URI. So that gives you a standardized way to link to a questionnaire that's being used for something SDOH related or otherwise, or to provide more information about tribal affiliations or jurisdictions. So you can find that full list at the linked page, and it's definitely a useful resource for folks who are looking at how to move from US CDI version 1 to version 3 within FHIR. Any questions, comments, or thoughts there? All right, let's move on then. This was interesting. So we're moving into the security section of the updates. CMS put out some guidance for around texting patient information at hospitals. So this is texting from one provider or other staff member to another within a hospital setting. It is not leaving that setting. And so they talk about both just generically patient information as well as patient orders. And specifically, they say that the computerized provider order entry remains a preferred method of order entry by providers. But if you really want to, you can use text as long as you're using a HIPAA compliant secure texting system and that the text meet the conditions of participation for CMS programs. And they call out some of what that entails that have to be secure and encrypted. I assume that would be given under the HIPAA compliant secure texting system. Every user must be authenticated. Again, I would assume HIPAA would require that too. I don't actually know. I haven't actually looked at what a HIPAA compliant secure texting system requires. So I'm not 100% sure. That's actually something that would be interesting to look at. But the other thing is that even if you're texting, all records, including all texts, have to be stored and maintained in the system of record. So you can use the text, but the text can't just go to the person you're texting. They have to go into the patient records. So you have to be able to like text them to the other provider and the EHR, or the other provider and the data warehouse where orders are stored, or something like that, so that they become part of the official patient record for that patient. So it's not a very long document, and almost everything it says is captured in this slide, but you can find it at the link if you'd like to learn more. Any thoughts or comments or questions there? All right, let's move on then. So as I mentioned, the security portion. So NIST has put out a new guide that outlines ways to consider cybersecurity when addressing the HIPAA security rule. And what it essentially is a mapping from the HIPAA standards and implementation specifications to the NIST cybersecurity framework, subcategories, and security controls. So it lets you use the NIST frameworks to comply with HIPAA, basically. It also provides a variety of additional resources. So there are links relevant to each security rule, and that gives you more information. And the last thing it does is have an appendix with a categorized list of other resources. And they cheated a little bit because the appendix is not actually in the document. The document says, see appendix on our website. So what you have as the two links are the guide, which again says see the appendix on our website, and the link on the website to the appendix. So any thoughts or comments or questions there? It seems to me like this is a really interesting and useful approach, because the NIST cybersecurity framework is a very widely used framework, and being able to directly do that mapping to say, well, we have to comply with HIPAA, and we're using this industry standard framework to do it, and we have this official mapping that shows us that we're doing that in a reasonable way, seems to me like a really good thing. All right, well then let's move on if no one else.
Yeah, I'll make a
go ahead.
comment on this. Since I'm the security officer
Yeah.
here, I definitely feel like this is a good idea, and it actually happens today already. We do our annual security audit, and there's always a mapping from the cybersecurity framework. Well, I guess maybe the CSF is the one I'm thinking of, which is the cybersecurity
Yeah,
framework.
this is the CSF.
OSF. Yeah, this is the NIST version of that, I guess, the specifically described NIST cybersecurity framework, which is the one that most security firms use to map out their categories and their framework. So it's a good idea, because then you can tie directly back to those requirements in the security or other rules as they may evolve over time.
Well, I think the thing here is that you're right that people do it, but this gives you a standardized way, so everyone's mapping them exactly the same way, assuming that they actually use the official government guide for it.
Right.
So I would think that this would be something that security firms or people who might do risk assessments for people would do well to adopt. And therefore, I think it would give it extra oomph if they're using the NIST approved mechanism for doing that mapping.
Yep. It's all good.
All right, well, let's go ahead and move on. And continuing on the security front, there's a new bill in the Senate, which is in its very early stages, called the Strengthening Cybersecurity and Healthcare Act. And what it basically does, again, it's very early on, it hasn't even gone through committee yet, but if it were adopted into law, it would require HHS OIG to perform various cybersecurity testing at least once every other year, and then report the results back to Congress. And it calls out pen testing, and it also talks about having to cover all mission critical systems or sensitive data, including patient data. And the patient data must include Medicare ID numbers, and then anything that impacts patient safety. The report also has to include any plans that HHS makes to update their cybersecurity protections, and then sort of some information about how these audits and this testing is being funded, and additional requests from OIG to Congress on how to either improve the system or that they need this funding increased in order to carry out this remit. So you can find out more at this link. You can also get alerts on the status of the bill. I'm signed up to do that, so I will bring back to the group more information as the bill progresses, if it does progress. But I thought that was an interesting bill. And note that it's a Senate bill, but it was proposed by the Republicans and allowed to go through, so it clearly has bipartisan support. So any other thoughts or comments there? All right, then moving on. I believe this is our last update. I just consolidated a bunch of ONC blog pieces that have come out since our last meeting. So there's a Behavioral Health Information Technology Initiative from ONC and SAMHSA. You can read a little bit more about it at that link. It's still in its early days, so I'm sure there'll be more about it as that progresses. They also provided some takeaways from ONC SDOH listening sessions that happened primarily last year. And they talk a lot about community stewardship, collaborative governance, and vendor agnostic data exchange, and then also getting the community service organizations more engaged in standards development. And these are a lot of the same things that we talk about a lot, so I thought it was worth pointing out. And the link, just note that there are also links to slides from some of the presentations and recordings. And then the final one is that they put up an article about population data and analytics driven by FHIR API requirements. It's actually specifically about a Boston Children's Hospital tool that uses bulk FHIR to gather patient data and then analyze the clinical notes, de-identifying the patient data and then aggregating multiple hospitals together. And then it allows you to do certain health metrics monitoring for patient data cohorts as well. So it was kind of a interesting tool because it does a bunch of different things and allows you to do a bunch of monitoring, and it's basically driven by bulk FHIR. So you can find each of those articles at the links on the page. And anyone want to comment or have any thoughts on any of those things? All right, if not, why don't you go to the next page and pause there. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.